Monika Jain, we all know, is a senior gastroenterologist at Bala Medical Institute and working as the chief of gastroenterology and hepatology in the institute. She is an alumnus of the prestigious GB Pant Hospital, from where she has done DM more than years ago. Post her DM, she worked as assistant professor in the same department, and since then she's been more than 30 years into practice, and she's an expert in the field of endoscopy as well as hepatology. She's got multiple national and international publications to her credit. Today, we request her to share her views on interpretation of hepatitis viral markers. Over to you, ma'am.
Thank you, Nitin, for the kind words. I would be talking upon interpretation of hepatitis marker. As you all know, hepatitis is a very common clinical condition which all of us encounter in our day-to-day practice. And most of the patients, when they come with the symptoms, it's very difficult to differentiate different types of viruses just by looking at their symptoms. So viral serology comes in a big way that we can make out this particular disease is because of this particular virus. And interpretation is generally difficult, especially in hepatitis B. Now we have mainly 5 types of viruses: hepatitis A, B, C, D, and E. Out of them, A and E causes acute viral hepatitis. So the serological interpretation is very simple in these two. Whereas B and C, they cause chronic hepatitis. So we have 2 phases, acute as well as chronic. So we need to understand what all serological markers are going to help us. And D is an incomplete virus which goes along with B. So I will be discussing one by one each of them. First of all, coming to hepatitis B virus. Before interpreting the different serological markers, which there are maximum number of serological markers available in B, we need to know a bit about structure of hepatitis B virus. It's very simple to understand. There are 3 proteins which are available in hepatitis B. One is a surface protein, second is a E protein, third is a core protein. So these proteins, they give rise to different antigens: surface antigen, E antigen, and core antigen respectively. Inside is a DNA, double-stranded DNA, partially double-stranded DNA, and then comes a DNA polymerase. So this is a game of basically 3 antigens, 3 antibodies, and a DNA in hepatitis B. We must understand that in hepatitis B, these antigens which are available, against them we have antibodies also. And some of the antigens are picked up in acute phase, some are picked up in chronic phase. So there is a permutation combination. We all know acute phase of any antibody is IgM type and chronic phase is IgG type. Let's see how we go. First antigen, which is hepatitis surface antigen, this shows that the person is infected with hepatitis B. This could be acute or chronic. Just by looking at surface antigen, we cannot differentiate this is acute or chronic. Against surface, we have surface antibodies. This shows that person has been infected, person is immune to hepatitis B infection. This could be as a part of natural infection which he acquires during the lifetime, or he has been given vaccination against hepatitis B and has become immune. So just by looking at this, we just can say that this person is immune to hepatitis B. Second antigen is the E antigen. This antigen comes in the body when virus is actively replicating. So whenever virus is actively replicating, this antigen is secreted inside the blood. So we know that this particular virus is active. Against this comes the E antibody. This shows that the immune power of the person has taken over the viral activity, and now we have antibodies against this replicating virus. So now the person is non-replicative or less replicative, so this is less infective. Third antigen was a core antigen, but unfortunately we don't have any serological marker for core antigen because this antigen stays inside hepatocytes. So we cannot measure that. But fortunately, we have antibodies against core antigen. These antibodies are again of 2 types, IgM or IgG. I will explain that what is the clinical significance of that? And lastly is the HBV DNA. DNA is a marker that shows that how much is the virus and how much it is replicating. So 3 antigen, 3 antibodies, and a DNA. So permutation and combination of that shows that what will be the serological status of a person. Before coming to the serology, let me explain 2 important things. How a person gets hepatitis B infection, that is very important to understand. One is a vertical transmission when it is acquired from mother to baby. And second is a horizontal transmission in which from person to person infected data or sharing blood or all these, they lead to transmission that is known as horizontal transmission. So why this is important? This just you can see from this graph. If the person acquires this infection during birth time, at the time of birth or in perinatal period, look at the chronicity. This side shows the chronicity. So the chronicity rate is to the tune of 90%. So if a person or a baby gets infection in utero, and then the chronicity rate of this is 90%, that means almost all the babies are going to harbor this virus during their lifetime. Whereas if this infection is acquired at a later age, in older population or older children, around 5 to 10% of people are going to be chronic carriers. So this is important to understand. Whereas symptomatology, most of this group, which is harboring infection in utero, is asymptomatic. So to pick up this particular group, only serological markers are going to help us because these patients are not symptomatic. So it's very important to know the serology. I will show you, this is the table. When a person gets infection in a older age, then almost 90 to 95% people, they resolve this infection. That means they clear their virus according to their immunity, and only 5 to 10% they go on to chronic state. Out of them we have two groups. One is a inactive carrier in which the virus is there but is non-replicating and is present there, or in 15 to 20% patients there is chronic active hepatitis. We all know that leads to cirrhosis or ultimately develops into liver failure or liver cancer. So just look at that. If 100 people are infected, very few are going to have liver failure and liver cancer. 90 to 95% are going to resolve. So to age a virus is very important when we see a patient who is coming with the hepatitis B positive state. Just now, let's take a typical case of acute viral hepatitis due to hepatitis B virus. Just look at this graph. What will happen? Surface antigen will appear in acute phase. It will stay during the symptomatic phase, and it will go off in around 24 weeks. That means in 6 months, most of the people are going to clear this virus. Surface antibodies will appear around, you can say, 4 to 8 weeks after this disappearance. Surface antibodies are going to be there and they stay for the lifelong in most of the people, but few persons, they have low titers or they lose their surface antibodies. The second antigen I have already told, that was core antigen, which we cannot measure, but core antibodies of IgM variety, they come, they peak and they drop at 32 weeks. So there is a phase when we have lost surface antigen, we don't have surface antibodies, and this is a window period. So window period diagnosis can only be made by detecting core antibodies of IgM variety. Later on, what happens, this IgM variety over a period of time gets converted into total core or IgG variety, which stays in the body for lifelong. This is a very important antibody to understand, because if a patient gets hepatitis B infection and clears the surface antigen, and surface antibodies are in low titers, and at that time, if we want to tell that this particular person had B infection, the only marker will be total core antibody. E antigen status, what will be the status of E antigen? It will come and will be replaced by antibody to E antigen. So this will show the replicative state and this will show the low replicative state. So let's revise what will happen in acute viral hepatitis. We have an early phase, we have a window phase, we have a recovery phase. What will be the markers? Surface antigen in early phase, surface antigen will be positive, E antigen will be positive, IgM type of core antibodies will be positive because IgM is an acute phase reactant, and DNA will be very high in acute phase. Next comes the window phase. What will happen? Surface antigen is cleared, E antigen has cleared, antibody to surface and E antibody are yet to appear. The only marker which is going to be positive is the core IgM core antibody, which is going to be positive. DNA may or may not be positive. Next comes the recovery phase. What will happen if the person has already cleared the virus? Surface antigen will become negative, E antigen will become negative, IgM core will become negative because acute phase has gone. IgG variety of core antibody will be positive, surface antibodies will be positive. E antigen is replaced by now E antibody. So the markers will be all three antibodies. IgM core, IgM core will be negative. So this is the recovery phase. Now let's come to what will happen in serology in chronic phase. What happens when do we label a person as chronic? When a person acquires acute infection and is not able to clear this virus after 6 months, then we label this person as a chronic HBV infection. So surface antigen will come, will stay, will not be cleared, and will stay in the body. So a person who is coming with chronic hepatitis B will continue to have surface antigen. The core antibodies, I have already told, in acute phase we have IgM. They will come, they will go away and will be replaced by total core. So the total core will stay throughout the life. E antigen will come, may stay, or may be replaced by anti-E, depending on the replicative status of the patient. So that in chronic phase we have surface antigen, we have total core, and E or anti-E combination. So by these combination, let's see what all phases we can have. We can have non-replicative phase, we can have replicative phase, and a pre-core mutant. I will just discuss what will happen in pre-core. First, see the non-replicative phase. That means the virus is present in the body, but is not replicating. So the markers, what markers will be there? Surface antigen will be positive. Because this is a replicating virus, E antigen will be positive. E antibody will be this is a non-replicative virus, so surface antigen will be positive, E antigen will be negative, E antibody will be positive, and IgG variety of core antibody, because this is a chronic infection. So we have no DNA, we don't have E antigen, we have only surface antigen. This shows that this person is there harboring the virus, but that is in non-replicative phase. Now look at the serology in replicative phase, when the person is having infection for more than 6 months and the virus is replicating continuously. What will be the serological profile? Person will be surface positive, person will have E antigen which is positive, IgM core variety will be negative because the acute phase is over, and IgG variety of antibody will be positive and DNA will be very high. So in replicative phase, the main markers of replication, that is E antigen and DNA, both will be very high. Next, a condition which is known as pre-core mutant. Pre-core, this is a defective virus in which there's some sort of mutation occurs, so that it shows that the person is having replicating virus, but E antigen somehow is not secreted because the gene which is coding for E antigen is becoming mutated. So in spite of replication, we don't have E antigen. So what will be the status? The surface antigen will be positive. The E antigen, although replicating, will not be positive. Core antibody, IgG variety will be there. E antibody will be high and DNA will be high. So to know the pre-core mutant, we have surface positive, E negative, but very high DNA. So DNA comes to rescue and to diagnose these pre-core mutants. Next comes the serology in immune person. If a person gets immunity by, say, natural infection versus vaccination, can we differentiate these two groups? Yes, we can. Surface antigen will be negative in both the cases because the person is immune. surface antibody will be positive in both the groups. But if person gets this infection, B infection, and gets immunity, then core antibody, I have already told, that stays for the lifelong. So this will be positive in natural infection, and this will not be there in vaccination. We get sometimes we get calls from blood donation, these blood banks, that the person is otherwise surface negative, but he is having isolated core antibody positive. So this is not a very uncommon finding. It's seen in around 2% of donors in low endemic area and around 10 to 20% in high endemic area. So what is the interpretation? Why we should know about this marker? This shows there are two possibilities. One is a person had a past infection with HBV and his anti-HBs status, the surface titers, the titers of surface antibodies have come down. So the only marker which will be present is core antigen, core antibodies. Or the patient is in window period. I have already described in acute viral hep. So these are the two states in which these antibodies are going to be present. So what is the clinical significance of this? That these donors are generally rejected in organ donation or blood donation, because in spite of clearing virus, sometimes the CCC DNA, the covalently closed DNA, stays inside the hepatocytes. So these donors are not taken up for blood donation or organ donation. Next, lastly comes the HBV DNA, which we do by real-time PCR. And what is the clinical significance of DNA? DNA has been a very important marker which we assess in patients with chronic hepatitis B to start therapy in wild type. Wild means E antigen positive group. We take a cutoff of 20,000 IU per ml, and pre-core mutant, this is 2000 IU per ml. Treatment monitoring also is generally done by HBV quantification, treatment response, especially in pre-core mutant group, reactivation of non-replicative HBV state, and diagnosis of fulminant failure in HBV infection. Sometimes what happens, a patient comes in fulminant failure and none of the marker is positive, because the antigen or antibodies, they are not get come up. The only marker which is going to be positive is HBV DNA. So to label a person is having fulminant failure because of HBV, only DNA sometimes help us to diagnose this. Recently, there is a lot of interest which has come out in HBV genotypes. Almost 10 types of genotypes have been seen. A, C, D are common in India. What is the clinical significance of that? We can assess the treatment response, spontaneous seroconversion, pre-core mutation status, progression to cirrhosis, and incidence of HCC. All these have been linked to different genotypes. But what is their role in clinically is not yet. We need more data to say that this particular genotype is related to this particular state. So we need more studies to label it. Recently, a lot of interest have developed in HBS quantification. That means we not only say that this is HBs AG positive, we quantify also this antigen. So it has been seen there is a correlation between HBs concentration and intrahepatic level of CCC DNA, which is a marker of infection. Actually, if we want to say that this person has infected hepatocyte, we need to know about this CCC DNA, which is otherwise to measure from, we need to take out the biopsy, from that extract CCC DNA, and to measure that, this is a very cumbersome job. And now it has been seen that this circulating surface antigen concentration is an indirect marker of control of infection and is a surrogate marker to know the number of infected cells by hepatocyte, this HBV infection. So now prediction of stage of fibrosis also has been linked with the HBS quantification, development of HCC, and deciding the duration of treatment in patients, especially on nucleoside analogs. Because in interferon, we had a starting point, we had an end point, but in these nucleotide analogs, which we are nowadays using in HBV treatment, we can use HBS quantification. So we need more data to put this quantification in guidelines. It will come, and it is a very simple test. Now coming to hepatitis D, this is a basically incomplete virus, nothing much to say about this. This particular virus requires presence of hepatitis B, and when B and D both are there, the disease is more severe. The only diagnostic marker which is available is a HDV IgM variety. So what is the clinical significance if a hepatitis B patient becomes suddenly very serious and the complications are becoming more? Then sometimes we get this HDV done for IgM variety. Hepatitis C is the next marker, next virus, which is very important to understand, because now there is a paradigm shift in the management of hepatitis C. We used to think that C was a difficult virus to treat before, say, 2015. C was a difficult virus to treat as compared to B. Now we know that we can cure this, almost cure this hepatitis C virus. We should know the serological markers in the way. This is a acute typical graph of what happens when a person gets infected with hepatitis C. HCV RNA comes, either it clears or it stays in the body in chronic state and it fluctuates. The antibody is anti-HCV. This comes, rises and stays in the body for lifelong, and this ALT level comes, becomes peaks in symptomatic phase, then fluctuates. So the game is only HCV RNA, anti-HCV and ALT. Unlike hepatitis B, where we had seen in adulthood 90 to 95% people, they clear the virus. But in HCV, contrary, almost only 50 to 25% HCV infected people, they clear this virus. So the chronicity rate is very high, almost to the tune of 85%. So what are the markers which we have? We have anti-HCV antibody, which is used for screening to confirm this, because these antibodies can be falsely high in patients with autoimmune disorders, and sometimes in pregnancy also. These antibody needs to be confirmed by HCV RNA qualitative to say that yes, this person is infected with hepatitis C. And to further requiring the management part, we require the quantification of HCV RNA, which is done by PCR. And lastly is the genotype. Genotype is basically this hepatitis C is a very heterogeneous virus. It has got different genotypes, 1, 2, 3, 4, 5, 6, and with multiple subtypes. What is the clinical significance of that? We need to know what type of therapy we give to this patient, how long to treat that patient, what will be the response, to predict the response. We for that, for all these things, we require genotype testing. But recently there is a shift in this statement. Now we are getting pan-genotypic drugs. That means a drug is active against all the genotypes. So with time, maybe genotype testing may not be required. And another important point to understand is genotype does not influence the severity of liver disease. That means genotype A, B, C, D, that shows that any genotypic person can have a severe disease or mild disease. That does not depend on genotypic. Coming to hepatitis A, very simple virus, acute virus, no chronic state, orophycal transmission. We have only two markers. That is the antibody response to IgM variety or IgG variety. IgM means acute illness or recent vaccination, or IgG varieties or total. IgG or total are taken as one. So either the patient had a past infection or had an immune response to vaccination given to the person. This is a typical graph. Acute hepatitis, symptomatic phase, IgM variety of HAV comes and comes down. and total IgA stays for the lifelong. So if we want to say that this particular person was infected by hepatitis A, we just get a total anti-HAV done, and we can say, yes, this person is in. 90% of our population, 80 to 90% of our Indian population by the age of 20, they become positive for this. So next comes lastly, hepatitis E. Again, acute virus, no chronic state. We have both the types of antibodies, IgM and IgG. Incubation period 1 to 6 weeks. This is the last graph which shows that the patient becomes symptomatic. So in symptomatic phase, what will happen? IgM antibody will stay and will come down in around 12 to 13 weeks of exposure, and IgG is going to stay. So acute response IgM, chronic response IgE. So just by looking these two antibodies, we can say this person was infected with hepatitis C.